Welcome to the Cystic Fibrosis Foundation CF Education Day, CFTR2, information about CF mutations. My name is Leslie Hazel, Director of Patient Resources at the Cystic Fibrosis Foundation. This webcast is hosted by the CF Foundation and supported through an unrestricted educational grant from Genentech. We will be talking about the clinical functional translation of CFTR, also known as CFTR2 project, as well as information about CF genetics and disease-causing mutations. The CFTR2 project and website is designed to provide information about specific cystic fibrosis mutations for patients, families, healthcare providers, researchers, and the general public. If you have more questions about CF genetics, I encourage you to talk to your CF care center or find a genetic counselor who is familiar with cystic fibrosis. You can watch the webcast Orientation to CFTR2 website, information about specific CF mutations, to learn how to use it. This link to the CFTR2 website is on the Foundation's website. Joining me is Dr. Garry Cutting, Professor and Director of the CFTR2 project. Dr. Patrick Sosnay is the Assistant Professor and Coordinator of the clinical data collection and maintenance of the data within the CFTR2 database. So both Patrick and Garry are at Johns Hopkins University in Baltimore. So welcome, Garry and Patrick. So my first question is, what is the CFTR2 project and website?
So Patrick, I'll take this one. CFTR2 project is an ambitious project to categorize all of the mutations in the CFTR gene as to whether or not they cause disease. For many of the patients and families out there and the docs out there, you understand there's a large number of mutations that have been collected in this gene, almost getting up to close to 2,000 now. And the problem is that we don't actually know for sure which ones actually cause disease and which ones don't. And this has been a bit of an issue because as the years have gone by, genetic testing has become more and more a part of the care and management of patients, and certainly used in the diagnosis of patients. So the CF Foundation wanted to sponsor an international project to evaluate what we call the disease liability of the mutations in CFTR.
So where did all the information in this database come from?
So we wanted to start, Leslie, with the mutations that are seen in CF patients. And these are going to be the best culprits to be the mutations that are going to cause CF, the mutations that are associated with cystic fibrosis. So Garry assembled an international team to look not just at cystic fibrosis in the United States, but to get as best of a representative sample of cystic fibrosis worldwide that we could. Garry assembled the international team that you see on this slide. And we gathered database information like we have in the United States CF registry. They have a large registry in Canada that does the same thing, and some of the other larger European registries that we have as well. Starting with that, about 40,000 patients were able to identify the mutations that are most suspect to be the ones that cause CF, starting with those to try to identify, to confirm that they actually do cause disease.
So how many CFTR mutations are there? You mentioned almost 2,000. How many are there today?
So as of at least yesterday, there are 1,870 different CFTR mutations that have been described. And that's been well cataloged at another online database that you may have seen. That's the University of Toronto, or the Sick Kids Hospital database. And that database was actually started shortly after CFTR was recognized as the gene that causes CF, and initially was run by Lapsy Choi. Currently is run by Joanna Romans, Ruslan Dorfman, and Mary Corey up at the University of Toronto, who are collaborating with us on the CFTR2 project to link the two databases together.
Well, it's good to have that much information, especially with a rare disease like cystic fibrosis. So do all mutations cause CF?
So that question is obviously the basis of having the CFTR2 project, because not all mutations cause disease. But I think we have to discuss a little bit about what a mutation is and think about why, when you hear the term mutation, one thinks that it might be something bad. And in fact, from the point of view of genetics, that's not necessarily the case. So I can use the example of a word. And if a word were the gene, and if there were a misspelling in the word, you would recognize that as a misspelling, and you could call that a mutation. It's a change in one of the letters of the word. But you can also have different spellings of the same word, and it means the same thing, and that's also a mutation. It's a change in a letter in the word, and that's also viewed by geneticists as a mutation. So the challenge is deciding what are different spellings of that word we will call a gene, and what are actually misspellings of the word. So that's the challenge we face, and dissecting the two is sometimes quite difficult, because sometimes those misspellings or changes in the way we view those words and different spellings of words change over time. So with our better understanding and people sort of appreciating things. So it's a moving target is the other issue we have.
So that's why the number of mutations keeps growing. You're just trying to gather this information, and the Human Genome Project was just recently completed in the late 90s, and so this is still a fairly new science.
Yes, it is, not just for cystic fibrosis, but for many other diseases, determining whether a change, it is a misspelling or just a variable spelling or different spelling of that same word.
So are some mutations worse than other, and can you determine severity of disease based on the mutation?
That's a challenging thing to do, and it's very difficult on an individual patient-by-patient basis. So the first mutation that was recognized in the CFTR gene, delta F508 or F508 deletion, is still the most common mutation far and away that we see in CF patients. We recognize that that has a range of severity, but that range of severity is pretty broad. There are patients who have just 2 copies of the delta F508 that have such severe lung disease that they need a lung transplant at a young age. And there are other patients that I see in my adult practice that have 2 copies of the delta F508 that have near normal lung function, have to take medications, but are able to live a fairly normal life. So within that huge range, it makes it very difficult for any mutation to be able to predict for a single patient how someone with that mutation will do.
So is there any research going on to try and accurately predict severity of disease based on mutations?
There certainly has been. For 20 years, we've been studying this issue of can we predict disease from the type of mutation you have in the CFTR gene, and that's called a genotype-phenotype correlation. And it was recognized shortly after the identification of the gene that certain mutations in the gene would predict the severity of the pancreatic disease. And that's important because having more severe pancreatic disease can increases your risk of having diabetes at some point in your life, and it tends to be associated with more severe lung disease in general. However, for the lung disease, we haven't been able to ascertain a clear correlation between the mutations in the gene and the severity of lung disease, which, as Patrick just mentioned, is one of the challenging things, to have patients with the same mutations having very wide ranges in lung disease. So we know other things, we call them modifiers, contribute a lot to the severity of lung disease. But I think CFTR2, as I think you'll see when you look at the website, we're starting to now discover that there are correlations between the genotype, the changes in the gene, the mutations in CFTR, and the severity of lung disease, and also with the level of the sweat chloride concentration anomaly. So we're still moving ahead, we're still learning more, and that's where CFTR2 project is help us move forward with this genotype-phenotype correlation.
So define for me what you mean by phenotype.
So the phenotype is the constellation of features that a patient has. So if it's a patient with CF, it would be how severe their lung disease is, whether they have pancreatic insufficiency or not, and they have to be on enzymes, whether they've had meconium ileus when they were a baby, if they develop diabetes. That constellation is called the phenotype, the physical presentation of the illness. So that's why when we try to correlate the genotype being the changes in the gene, and the phenotype, which is the presentation of the illness in the patient. That's how we try to make those correlations. And is it certain mutations are more often found with, say, diabetes, or more often found with meconium ileus?
So how do you know if a mutation is a disease-causing mutation? And what's the difference between a disease-causing and a non-disease-causing mutation?
There are several different things that we try to do to identify a mutation as a disease-causing mutation. First of all, we want the patients that have that mutation to have CF. Remember, CF is a clinical diagnosis, so having the genetics alone is only part of enough to say that this particular person has CF or that this mutation causes cystic fibrosis. But as part of the CFTR2 project, we're also looking at the spectrum of disease seen by individuals with a given mutation. We're looking also doing laboratory-based tests in collaboration with some of our scientific colleagues to really look at that. For example, to look at that mutation under a microscope and look at how cells with that mutation behave, so that we both know the patients with that mutation have the symptoms of cystic fibrosis, lung disease, abnormal sweat chloride, pancreatic insufficiency, or meconium ileus, but also that cells that we look at in the individual analysis of the way a particular cell transport chloride also demonstrate manifestations that that particular mutation isn't working in that cell. So it's a combination really of the clinical features and the more lab-based functional analysis of a mutation.
So a little bit different directions. I get a lot of questions about variants, polymorphism, and mutations. Can you help define those for the people watching?
So the term traditionally for mutation, as viewed by geneticists, and this goes back to the days of Mendel, is that a mutation is basically any change in the DNA that is deviating from what's accepted to be normal. So you could sort of see this as any change in a word that you would see as that's normally the spelling of the word, and now there's a change in that word. However, as I just alluded to, you can actually have different spellings of the same word, has the same meaning. And so differentiating between mutations that change the spelling of the word and they actually change the meaning of the word versus those that preserve the meaning of the word is the challenge. So a mutation is any change in the DNA, whether or not it causes disease. Now the problem has been that due to Hollywood in the 50s and 60s, and I don't want to blame Hollywood completely, but this certainly has contributed to the concept that mutation, in particular the term mutant, meant something frightening on that big screen. And so that the term mutation took on a new connotation, which is something bad. And that's not still the way we view it. So in some cases where if we're not sure the mutation causes disease, the term variant was used. Well, we're not so sure it's a mutation, which we might imply that it's going to be severe and cause disease. So we'll use the term variant, which is sort of hedging your bets. We don't like to use variant too much because patients, I don't think, want us to hedge their bets. They want to try to be a little bit more definitive. Do I have something that causes disease or not? Again, that's the genesis of the CFTR2 project, to try to find between variant and mutation. The term polymorphism, another one that confuses a lot of people and certainly is one that floats around out there, is based on frequency. Polymorphism was based on variation in proteins and the building blocks of proteins called amino acids. And if you had a change in an amino acid in a protein that occurred in 1 in 100 people, it was called a polymorphism. And polymorphism actually means many faces. And that's what you're basically saying, is that there can be different versions of this protein. So you could sort of see polymorphism as a common way in which a word is differently spelled. Color and color, the way the British spell color versus we do in the United States, with a U in the UK and without in here. So they mean the same thing, but they're common enough. I would say that's a polymorphism in the word color.
That's a nice description, and that word spelling difference is a nice way to make something that's incredibly complicated a lot more understandable. Someone wanted to know, why is there very little information about rare CF mutations?
Well, anytime we're studying something that's uncommon, rare mutations, we're less able to make predictions on what the whole picture looks like. So for example, if there are only 10 patients worldwide with a given mutation, we're going to be a lot less able to say this is the range of phenotypes, this is the range of lung function, this is the range of sweat chloride that we see for people with those mutations. When you have a mutation like F508 delta, and there are thousands of patients worldwide, we have a better idea of what it is. So specifically, it's pretty easy for the mutations that are seen commonly to be able to say this is a CF-causing mutation, or this is just a neutral mutation or a neutral variant, like Garry talked about. But it's much more difficult for those mutations that are seen less commonly. And those are the challenges that we face as more patients are having DNA testing done to identify whether or not they've got CF, or to identify, for example, if they're a CF carrier. What do those rare mutations mean? That's hopefully what we're trying to fill in a little bit more with the CFTR2 project.
So is it important for a person who has a clinical diagnosis of cystic fibrosis to know their genotype? And if so, why?
Yes, well, a geneticist might have one answer to that. But practically, I think if as Patrick noted earlier, CF is a clinical diagnosis. Always has been, and I think always will be. If you have features of the disease, the phenotype matches cystic fibrosis, and you have elevated sweat chloride, that is still the diagnostic criteria for cystic fibrosis. Over the past, say, decade or so, it's become more apparent that knowing the genotype is important. One of the things that has been helpful is to determine whether or not your pancreas is going to continue to work if you are pancreatic sufficient when you're young. Will I remain pancreatic sufficient? And that's about 10% of patients. And those patients don't necessarily have to have enzyme replacement. That is of some value because, as I mentioned earlier, knowing that you have preserved pancreatic function, you're less likely to get diabetes, your lung disease may be a little bit less severe, so there's some value to that. However, as far as predicting lung disease, as we mentioned earlier, it's not that useful. However, things are changing. Now that the CFTR2 project is rolling, I think we're going to better predict the correlation with lung disease. We're going to be able to predict to a better degree the correlation with sweat chloride. But in addition, therapies that are specific for certain mutations are now being developed. There's been incredible excitement over the development of compounds that are safe to use in patients, that have now gone through almost a year's worth of trials, that have demonstrated success working on a specific mutation. Now, we all think that that list of mutations is going to increase, but I think many patients out there want to know, do I have a mutation that is going to respond to these new compounds and therapies that are being developed? And of course, that's something we want to be able to provide that information. But at this point, I think the best thing to be considering is it might be valuable to be genotyped so that we know ahead of time what mutations you carry so that we can make some decisions as to what's the best therapy. Because not only is the mutation developed for this mutation called G551D, but there's other mutations being developed for something called nonsense mutations. We are very hopeful about mutations that will, therapies that will work for the delta F508 mutation, the common one that many patients carry. So I think it's an evolving picture. There's going to be more use in knowing the mutations for predicting outcome to some degree, but equally, or perhaps more importantly, now the type of therapy a patient may get will be dependent on their mutations or their genotype, as we call it.
So how do you see researchers and healthcare professionals using this database? And then the more critical question, how do you see people with CF and family members or people who are carriers using this information in the CFTR2 database that'll be in the website?
So I'll start with the researchers and healthcare perspective first, but we would expect researchers in healthcare to use this database really as a tool integrating with the CFTR1, the Toronto Sick Kids database, to have a catalog of these are the mutations that we know cause CF. So a clinician, for example, might use this if on newborn screening you see a newborn and they have a lower sweat chloride that's maybe in the intermediate range in between clearly CF and clearly not CF. And many states will do genetic testing as part of that newborn screening, to be able to go to that newborn screen genetic test and say, oh, this mutation, I may not have heard of it, but here's a resource where I can look stuff up to see what's known about this mutation. Do we know that it causes CF? Do we know that it does not cause CF? It's a neutral mutation or a neutral variant, or is it somewhere in between? That sometimes patients have CF, sometimes they don't. For researchers, I think it's going to be helpful as well, because it's going to help us to explain really the range of disease that we see in CF and all the different ways that a mutation can be a mutation. And it may be helpful in pointing out certain scenarios where we would expect a mutation to be more or less severe, kind of give us a lead to do further research to understand how that mutation works. From patients' point of view, and we really want this database, this website to be used by patients, this really represents a starting point. With all information on the internet, you can't use this information alone to make medical decisions. This is an introduction into a very, very complicated field of CF genetics. So we'd encourage patients or family members or people that are going for carrier screening, if there's stuff they don't understand, to print it out and discuss it with their primary provider, their CF care team, or especially with a genetic counselor that's well-versed in cystic fibrosis.
So the last question, what is the future for this CFTR2 database? Where's this going?
Well, I think when we started the project, we thought we'd have some clear endpoints. And I think that as the project has grown, and we've gotten a lot of very positive feedback from people about the value of doing this, I think we have decided that we're going to push ahead as far as we can to provide as much information as we can about these mutations, including the rarer mutations that are only carried by a few people in the world. But we feel that if we can provide that information in a high-quality way, and because the foundation's supporting this, I think patients and family members can trust the source of this information. So I think we're going to continue to evaluate the mutations that are found. There's 1,870 or so, Patrick, you said. We have about 1,100 mutations actually in the database currently. We've sorted out about 160. I must say we started with 23 that were well understood. We've now moved to 160 where we feel confident, and you'll see that a list of 160 in the database when it goes live. Our next goal would be to go to 270 or so, and that 270 will account for about 99% of all of the genes that have CF, that cause CF out there. Because some of the mutations can occur over and over again. Then the big challenge will be finishing off the other 1,000 or so, maybe more than that, 1,500 or so mutations, that we will, over time, working with a group of scientists primarily, who will help predict the effect of these mutations on the function of the gene, will help us, again, provide insight into the whether or not a mutation is disease-causing. But please give us time. We are working on the other mutations. If you have a rare mutation that's not listed on the database, we are going to try to place everyone that we have in the resource. We may say we don't have any information on it yet, but I assure you we are working on it. And I think you'll see that the list of mutations for which we feel confident we can make a call will increase over the next few years. So we'll move from 23 to 160, then we hope in another year or so to add another 100. And then after that, it'll be probably chunks of mutations at a time as we move forward.
So this is where it's really important for people with CF to participate in their country's patient registry database, because that's where you guys are going to be collecting the information from. So no matter what country they're in, if they're asked to participate in the database, it helps you if they say, yes, you can put my information, my mutations, my symptoms, and how CF presents itself into the database. So thank you, Garry. Thank you, Patrick. This concludes the Cystic Fibrosis Foundation CF Education Day, CFTR2, information about CF mutations. I encourage you to watch the webcast about the orientation to the CFTR2 website that's also available on the Foundation's website. Also, if you have any questions about CF mutations and the genetics, please talk with your CF care center or a genetic counselor who is familiar with cystic fibrosis. I would like to thank you for watching, Garry and Patrick for answering all of the great questions that have come in, Rick Vast and the technical crew, Melissa Chin, the Foundation for supporting this and making this possible, and Genentech for their unrestricted educational grant. Thank you.